Hello again, it's podcast number 3. Omar again with you. Today I'm gonna talk about the stroke. What is the stroke? A stroke, sometimes called brain attack, occurs when something blocks the blood supply to the part of the brain or when a blood vessel in the brain bursts. In either case, part of the brain becomes damaged or die. A stroke can cause lasting brain damage, long-term disability, or even death. What happens in the brain during a stroke? The brain controls our movements, store our memories, and is the source of those emotions and language. We know this. The brain also controls many functions of the body, like breathing and digestion. To work properly, brain needs oxygen. Arteries deliver oxygen rich blood to all parts of your brain. If something happens to block the flow of blood, brain cells start to die within minutes because they can't get oxygen. This is called a stroke. So what are the types of stroke? There are two types of stroke: ischemic stroke and hemorrhagic stroke. Most strokes are ischemic stroke. An ischemic stroke occurs when blood clots or other particles block the blood vessels to the brain. Fatty deposits, called plaque, can also cause blockage by building up in the blood vessel. A hemorrhagic stroke happens when an artery in the brain leaks blood or ruptures. The leaked blood puts too much pressure on brain cells, which damage them. High blood pressure and aneurysms, balloon-like bulks in an artery that can stretch and burst, are examples of conditions that can cause a hemorrhagic stroke. Transient ischemic attack, TIA, or mini stroke. TIA is sometimes known as warning stroke. It's important to know that TIA is warning sign of future stroke. TIA is a medical emergency just like mild stroke. Strokes and TIAs requires emergency care right away if you feel signs of a stroke or see symptoms in someone around you. There is no way to know in the beginning whether symptoms are from TIA or from other type of stroke. Like ischemic stroke, blood clots often cause TIAs. More than a third of people who have TIA and don't get treatment have mild strokes within a year. As many as 10% to 15% of people will have a mild stroke within 3 months of a TIA. Recognizing and treating TIAs can lower the risk of a mild stroke. If you have a TIA, your healthcare and team care can find the cause and take steps to prevent a mild stroke. Let me talk about the risk factors. First of all, let me talk about the uncontrollable risk factors. First, previous stroke or a transient ischemic attack, TIA. Family history, genetics, age. For example, the older you are, the more likely you are to have stroke. The chance of having stroke about double every 10 years after age 55. Although stroke is common among older adults, many people younger than 65 years also have stroke. Experts think younger people are having more strokes because more young people have obesity, high blood pressure, and diabetes. Let's talk about sex, another uncontrollable risk factor. Stroke is more common in women than men, and women of all ages are more likely than men to die from stroke. Pregnancy and use of birth control pills pose special stroke risks for women. Race or ethnicity, another uncontrollable risk factor. People who are Black, Hispanic, American, Indian, and Native Alaskan may be more likely to have stroke than non-Hispanic, white, or Asians. The risk of having a first stroke is nearly twice as high for Blacks as for whites. Blacks are also more likely to die from stroke than whites. Now, controllable risk factors, modifiable factors. High blood pressure. High blood pressure is a leading cause of stroke. It occurs when the pressure of the blood in your arteries and other blood vessels is too high. There are often no symptoms of high blood pressure. Get your blood pressure checked often. If you have high blood pressure, lowering your blood pressure through lifestyle changes or medicines can also lower your risk for stroke. High cholesterol. A blood test can tell your doctor if you have high levels of cholesterol and triglycerides, which is a related kind of fat in your blood. By the way, I am having high cholesterol, but I am controlling the situation with going to gym, and my diet plan, lifestyle to 100% effect will decrease it. It will gym is heaven, I swear. Heart diseases. Another controllable risk factor, modifiable risk factor, is heart disease. Common heart disorders can increase your risk for stroke. For example, coronary artery disease increase your risk for stroke because plaques build up in the arteries and block the flow of oxygen-rich blood to the brain. Other heart conditions such as heart valve defects, irregular heartbeat, and enlarged heart chambers can cause blood clots that may break loose and cause a stroke. Diabetes Diabetes causes sugars to build up in the blood and prevent oxygen and nutrition from getting to the various parts of your body, including brain. Obesity. Again, go to the gym. Obesity is linked to higher bad cholesterol and triglyceride levels and to lower good cholesterol level. Obesity can also lead to high blood pressure and diabetes. Sickle cell disease. Another controllable factor. Sickle cell disease is a blood disorder linked to ischemic stroke that affects mainly black children. The disease causes some red blood cells to form an abnormal sickle shape. A stroke can happen if sickle cells get stuck in the blood vessel and block flow of blood to brain. Medications and carotid stenosis and stress also are other controllable risk factors. What behaviors increase the risk of stroke? Eating a diet high in saturated fat, trans fat, and cholesterol has been linked to stroke and related conditions such as heart disease. Also, getting too much salt, sodium in diet and rise blood pressure levels. Not getting enough physical activity can lead to other health conditions that can rise the risk for stroke. These health conditions include obesity, high blood pressure, high cholesterol, and diabetes. Regular physical activity can lower your chance for stroke. Drinking too much alcohol is another bad behavior, can rise your blood pressure levels and the risk for stroke. It also increases levels of triglyceride, form of fat in your blood that can harden your arteries. Tobacco use, cigarette, cigar, shisha, hookah, any kind of those. Tobacco use increases the risk for stroke. Cigarette smoking can damage the heart and blood vessels, increasing your risk for stroke. Nicotine raises blood pressure. You have carbon monoxide from cigarette smoke reduces the amount of oxygen that your blood can carry. Exposure to the second-hand smoke can make you more likely to have a stroke. Associated conditions. Coronary artery disease is a major cause of death during the first 5 years after stroke. How will diagnose a stroke? Stroke signs and symptoms we have a lot, but let me talk about the most important. First, sudden numbness or weakness in the face, arm or leg, especially on one side of the body. Sudden confusion, trouble speaking or dirty understanding speech. Sudden trouble seeing in one or both eyes. Sudden trouble walking, dizziness, loss of balance or lack of coordination. Sudden severe headache with unknown cause. How you can identify the stroke? The stroke treatment that works best are available only in the stroke is recognized and diagnosed within 3 hours of the first symptom. Stroke patients may not be eligible for this if they don't arrive at the hospital in time. We can use a trick called FAST to identify the stroke. F letter which related to the face, like we should ask the person to smile, and we will check that if one side of the face will drop or two sides of the face will drop, and we will see if it's the normal smile or no. Letter A, it belongs to arms. We will ask the person to raise both arms. We will check if one arm drifts downward. The letter S, related to speech. We will ask the person to repeat a simple phrase, and we will check if the speech slurred or strange. Letter T belongs to time. If you see any of these signs, call hospital. Note the time when any symptoms first appear. This information helps healthcare provide determine the best treatment for each person. So a question came like, what should I do to treat TIA or mini stroke? So if stroke symptoms go away after a few minutes, may have had a TIA. Also sometimes call it mini stroke. Although brief, a TIA is a sign of a serious condition that will not go away without medical help. Unfortunately, because TIA clear up, many people ignore them, but paying attention to TIA can save your life. If you think you or someone you know has a TIA, tell healthcare them about the symptoms right away. How you will make a physical exam to diagnose? First, assess airway, breathing and circulation, ABC. Second, anterior or carotid circulation, hemiparesis, hemiplegia, neglect, zia, visual field defects. Third, posterior vertebrobasilar circulation, diplopia, vertigo, gait and limb ataxia, facial paresis, Horner syndrome, dysphagia, dysarthria, alternating sensory loss. Deep diagnosis. First, margin, complicated. Second, post-tical state, thought paralysis. Third, systemic infection including meningitis or encephalitis. Infection also may uncover or enhance previous deficits, toxic or metabolic disturbance, hypoglycemia, acute renal failure, liver failure, drug intoxication. Fourth, brain tumor primary or metastasis. Fifth, head trauma, encephalopathy. 6 other types of intracranial hemorrhage: epidural, subdural, subarachnoid, trauma, septic, embolic. The most commonly used classification system is Glasgow Coma Scale. The Glasgow Coma Scale uses a score to identify the level of conscientiousness from 1 to 15, with 15 being a normal state of consciousness. This scale takes into account verbal, motor, and eyes response to stimuli in determining the overall score. Initial tests: serum glucose (REGUIRET) required to exclude hypo and hyperglycemia (ECG). Second, CBC electrolyte panel coagulation studies (PTT INR). Third, markers of cardiac ischemia. Emergent brain imaging is non-contrast CT or brain MRI with diffusion weighted to exclude hemorrhage. The fourth one, and it can be life-saving. Fifth, subsequent multimodal CT, perfusion CT, CTA, and enhanced CT or MRI improves diagnosis of acute ischemic stroke. Tests consideration: first, consider LFT, stroke skin, blood alcohol, APG. Second, lumbar puncture if suspected subarachnoid hemorrhage, SAH. EEG if suspect seizures, blood type, and cross. DW MRI is more sensitive than CT for acute ischemic stroke. MRI is better than CT for diagnosis of posterior fossillation. Do not delay emergent treatment, IV thrombolysis, to obtain advanced imaging studies. Generally, if symptomatic, and an enhanced brain CT is emergently performed to exclude hemorrhagic and thrombolytic are initiated immediately unless contraindicated. Confirmatory MRI is not required in the most cases. Follow-up carotid imaging, Doppler ultrasound, CTA or MRA of head and neck after treatments is initiated. Last one, goal is initiate therapy within 60 minutes of presentation and initial examination. DIAG prostate surgery, echocardiogram, transthoracic and transesophageal if there is suspicion for cardioembolic source. In cryptogenic stroke patients, perform prolonged ECG monitoring within 30 days event monitor. Interpretation: early CT findings of ischemic hypertense MCA sign, increased attenuation of proximal portion of the MCA associated with MCA thrombosis, loss of gray-white matter differentiation, sulcal effacement, loss of insular ribbon. General prevention: smoking cessation, regular exercise, weight control to maintain non-obese BMI and prevent type 2 diabetes. Control the blood pressure, manage hyperlipidemia, use antiplatelet agents, for example aspirin, in high-risk persons. Treat non-valvular arterial fibrillation with dose adjusted warfarin or dabigatran, pixaban, and rivaroxaban. So for the treatment, maintaining good oxygenation. Systemic hypoxemia and hypotension should be avoided and, if present, corrected to limit orbital cellular damage. Supplemental oxygen should be provided to maintain oxygen saturation bigger than 94. Source of hyperarrhythmia: temperature more than 38 Celsius degrees should be identified and treated, and antipyretic medications should be administered. Now, blood pressure management. Labetalol 10 to 20 mg intravenously over 1 to 2 minutes, which may be repeated once. Nicardipine infusion 5 mg per hour, titrate up by 2.5 mg per hour at 5 to 15 minutes intervals to maximum of 15 mg per hour. Reduce to 3 mg per hour when target blood pressure is reached. Thiazide diuretics or ACEL or IRBS mechanisms. Monitor blood pressure closely in the first 24 hours. In people with a previous ischemic stroke or TIA, I suggest aiming for a blood pressure target of less than 130 over 80 mg Hg to reduce the risk of recurrent stroke. However, actually elevated blood pressure is necessary to maintain brain in borderline ischemic area. Withhold antihypertensive unless systolic blood pressure more than 220 mg Hg or diastolic blood pressure more than 120. Goal is to lower blood pressure 50%, nearly 50%, in the first 24 hours of treatment undertaken. If thrombolytic therapy is planned, blood pressure must be less than 185 or 110 mg Hg prior to administration of thrombolytes. In acute spontaneous intracranial hemorrhagic stroke, goal blood pressure pressure 160/90 mg/Hg. If there is suspicion of elevated ICP, reduce blood pressure to target cerebral perfusion pressure of between 61 and 80. Start antihypertensive medication 24 hours after stroke onset for patients with a history of hypertension who are neurologically stable. Hypovolemia should be corrected with intravenously normal saline at 15 ml per hour unless otherwise indicated. Cardiac arrhythmias that might be reducing cardiac output should be corrected also. Also, we can use antiplatelets, aspirin alone, loading dose 325 mg daily, then 48 hours or 24 to 48 hours after thrombolytics therapy. Maintenance dose 75 to 100 mg per 24 hours. DAPT, aspirin plus clopidogrel 75 mg, then 24 hours of AIS or TIA for 90 days, then 24 hours of minor stroke for 21 days. In people with previous ischemic stroke or TIA ESO, European Stroke Organization recommended against use of dual antiplatelet therapy with aspirin and clopidogrel. In the long term, recommended use of a single antiplatelet to reduce the risk of recurrent stroke. Anticoagulants. The results of several clinical trials demonstrate an increase in the risk of bleeding complications with early administration of either UFH or LMWH. Early administration of UFH or LMWH does not lower the risk of early recurrent stroke, including among persons with cardioembolic sources. Daily 24-hour if patient has received alteplase. In people with an embolic stroke and determined source, European Stroke Organization suggests use of antiplatelet therapy and not a DOAC, direct oral anticoagulant drug, to reduce the risk of recurrent stroke. So use LMWH 40 mg per 24 hour or heparin 5000 units per 12 hour. In case of thrombolysis, intravenous administration of RTPA, tissue plasminogen activator, alteplase, infuse 0.9 mg per kg, maximum dose 90 mg over 60 minutes within 10% dose given as bolus over 1 minute. Do neurologic exams every 15 minutes during infusion, every 60 minutes for next 6 hours, and then hourly until 24 hours after treatment. Discontinue infusion and brain emergency CT scan if you have severe headache or angioedema or acute hypertension or nausea and vomiting. Measure blood pressure every 15 minutes for the first 2 hours, then every 30 minutes for next 6 hours, and then every hour until 24 hours after treatment. Maintain blood pressure less than 185/105 mg/Hg. Follow-up CT scan at 24 hours before starting anticoagulants or antiplatelet agents. Individualized discussion about the use of intravenous thrombolysis with eligible patients who have measures neurologic deficits that do not clear spontaneously and present within 3 to 4.5 hours of stroke symptoms onset. Exclusion criteria for thrombolysis within 3 hours of onset including symptoms suggested of subarachnoid, hemorrhagic SAH, head trauma or prior stroke within 3 months, MI within 3 months, GI or gastric ulcer hemorrhage within 21 days, minor surgery within 14 days, arterial puncture at non-compressible site within 7 days, any history of intracranial hemorrhage, elevated blood pressure, historic more than 185, diastolic more than 110, active bleeding of evidence of acute trauma and examination, taking anticoagulant and INR, activated PBT not in normal range if heparin received during previous 48 hours, platelet count less than 100,000 mm, blood glucose concentration less than 50 mg, seizures with posterior residual neurologic impairment, multilevel infarction on CT, hypodensity more than 1/3 cerebral hemisphere, patient or family members not able to provide input and understand potential harms and benefits of treatment. Extended AHASA exclusions criteria for thrombolysis within 4.5 hours include age more than 80 years, all patients taking oral anticoagulants regulars or INR, National Institute of Health NIH stroke scale more than 25, history of stroke and diabetes, antiplatelet agent start oral aspirin, initial dose 325 mg within 24 to 48 hours, evidence of ischemic injury more than 1/3 MCA. Now hypoglycemia and hyperglycemia. In case of those, keep patients NPO until a full swallow evaluation has been performed to reduce risk of aspiration pneumonia, elevate head of bed to 30 degree. Hypoglycemia can cause neurologic dysfunction occurred during initial evaluation. If BG less than 60, give it 25 milliliter of hyperglycemia within the first 24 hours after stroke associated with poor functional outcomes. Insulin recommended for patients with glucose levels more than 140 to 180. In case of statin, high intensity sedation should be continued without interruption following stroke. Lipid lowering treatments should aim to keep the low density cholesterol level below 70 mg. In case of DVT prophylaxis, deep vein thrombosis DVT prophylaxis for immobilized patients. Maintain oxygen saturation more than 94%. Early physical therapy and discharge planning for rehabilitation and placement. Maintenance intravenously hydration with normal saline until swallowing status is assessed. Monitor fluid balance closely. Frequent neurologic exams in first 24 hours every 1-2 hours. All precautions, frequent response positioning to prevent skin breakdown. It's not beneficial and not recommended by ESO, European Stroke Organization, the neurogenic protective agents. Let me talk about the drugs used in catheter strokes and the mechanism of action of each drug, with dose administration, with contraindications, and drug interactions. So first drug we have terbolysine. Mechanism of action: cocaine brain-derived proteolytic peptide function, stimulates cell differentiation, bolster nerve cell function, induce mechanisms of protection and repair, increase number of glucose transporter molecules in BBB, reduction of neurodegenerative process. Dose administration: 1 ampoule 24 hours, intravenously bolus given and diluted, intravenously infusion, diluted up to 100 ml of RNS, Ranger solution D5W, infusion over 15 to 60 minutes. It has contraindication with epilepsy, cerebral renal dysfunction. Drug interaction with SSRI, MAOI, should use antidepressant agents. Second drug, piracetam, increases the energetic output of the brain cells and activates its neurological potentialities, especially when the brain cell is under condition of stress. Has no stimulating, sedative, or neurovegetative properties. Piracetam works by increasing the activity of chemical messenger acetylcholine with improved communication. Dose is 1.2 to 4.8 gram daily in 2 to 3 divided doses. Has contraindication cerebral hemorrhage. Now another drug, citicoline. Mechanism of action: stabilizes cell membranes by increasing phosphatidylcholine and sphingomyelin synthesis and by inhibiting the release of free fatty acids. Another mechanism, brain edema reabsorption. Another one, improved level of attention and consciousness. A given dose is 500 mg to 2000 mg daily. We can give it intramuscularly, intravenously bolus, and diluted over 3 to 5 minutes. Intravenous infusion, diluted up to 100 ml of NS. Ranger solution, D5W, infusion rate 4 to 60 drop per minute. Contraindications with parasympathetic hypertonia. Must not administered in concomitant of meclofenoxide. Another drug, meclofenoxide. The mechanism enhancing the memory and improving the cognitive functions of elderly. Another mechanism encourages the production of choline in brain, which is then synthesized into acetylcholine. The more acetylcholine neurotransmitters in the brain, the better and more efficient the cognitive functions will be. Meclofenoxide also increases cellular membrane phospholipids, also an anticoagulant agent. Dose given 1000 to 3000 mg daily for 10 to 14 days. So given intramuscularly, intravenously bolus, dissolved powder in solution over 3 to 5 minutes, intravenously infusion, diluted up to 100 ml of NS Ranger's solution. Contraindications: must not administered in concomitant of citicoline. Intoxifiline mechanism increases blood flow to the affected microcirculation. Its lowered erythrocyte flexibility is increased, leukocyte deformability is increased, and neutrophil adenosine and deviation are decreased. Overall tissue oxygen oxygenation is significantly increased. That's the mechanism. Dose 400 mg 2 to 3 times daily. No contraindication. Naftidraforil, it produces vasodilation of both cerebral and peripheral circulation, activation of intracellular aerobic metabolism, which may protect cells against metabolic effect ischemia by increasing ATP levels and decreasing lactic acid and antispasmodic properties. Dose is given 200 mg 2 times daily. Additional therapy, prophylactic antibiotics are not recommended at all. Corticosteroids are not recommended for cerebral brain edema. Refer to physical therapy, occupational therapy, and speech therapy as necessary. Inpatient consideration. Observe closely within 24 hours of neurologic decline, particularly due to cerebral edema. Elevate bed at least 30 degrees if elevated ICP suspected. Patients with ischemia, stroke may be verified horizontal bed position during the acute phase. Monitor cardiac breath for at least 24 hours to identify arrhythmias. Airway support and ventilatory assistance may be necessary due to dimensional consciousness or bulbar involvement. Reserve supplemental oxygen for hypoxic patients. Consider elective intubation for patients with malignant edema. In patients with ICH, secondary to anticoagulant use for REC and elevated INR with intervention vitamin K and fresh frozen plasma or prothrombin concentrate complex factor 7 infusion for patients requiring urgent surgical intervention. Surgical treatment. Ventricular drain may be placed for patients with acute hydrocephalus secondary to stroke, most commonly cerebral strokes. Compressive surgery is recommended for minor cerebral infarction. Considered for malignant middle cerebral artery infarction, especially in less than 60 years of age. Consider mechanical embolectomy in carefully selected patients who have evidence of salvageable tissue on advanced imaging. Carotid endarterectomy (CA) or carotid artery stenosis rarely is indicated emergent. CEA is indicated for more than 70%. Ipsilateral stenosis, CEA for TIA or incomplete stroke lesion may be indicated for 50 to 69% stenosis in carefully selected patients, depending on risk factor and skill and experience of surgeons. Carotid arteries are the blood vessels that run along each side of the neck, supplying the brain carotid arteries with blood. This surgery removes the blood blocking a carotid artery and may reduce the risk of ischemic stroke. A carotid endarterectomy also involves risk, especially people with heart disease or other medical conditions. Compulsory medicine discharge criteria. Medically stable should be the patient, adequate nutritional support, then neurologic status stable or improving follow-up. Issues for referral. Follow-up with neurologist 1 week after discharge with subsequent follow-up based on individual circumstance. Hemorrhagic stroke. Emergency treatment of hemorrhagic stroke focus on controlling the bleeding and reducing pressures in the brain caused by excess fluid. Emergency measures. If patient take blood thinning medication to prevent blood clots, he may be given drugs or transfusions of blood products to counteract the blood thinner effects. Drug used to lower the pressure in the brain, intracranial pressure, lower the blood pressure, prevent spasm of the blood vessels, and prevent seizures. That was all for today. I also become tired actually, but I have a holiday now, so I'll try to make as much as possible videos, podcast. Hope you guys all enjoyed and also benefit podcast for you guys. You can listen it as a radio. Thank you for attention. Omar was with you. Bye bye until podcast 4.